Okay, this is going to be Critical Care Pharmacology, Part 4, Cardioprotectants and Miscellaneous Drugs. Cardioprotectants, they are prophylaxis against an acute myocardial infarction. They pretty much decrease morbidity and mortality and the risk of actually having an MI. First one on our list is going to be aspirin. CNS agent, analgesic, salicylate, and antipyretic. Actions on this is going to inhibit platelet aggregation, or the clumping together of the actual platelets, decreases synthesis of blood coagulation factors. 7, 9, and 10 inhibits action of vitamin K. Indications: risk of myocardial infarction, coronary artery disease, angina, MI. Contraindications: allergies to salicylates, bleeding disorders, severe anemia, recent surgery or history of GI bleed. Side effects on this are going to be hypersensitivity reactions, anaphylaxis, obviously, bleeding, GI upset, thrombocytopenia or low platelet count, and nausea or vomiting. Dose on this, 81 to 325 milligrams daily. Special considerations: rule out any aspirin allergy before administering the drug. Cardioprotectants is beta blockers. This is our next item here. Metoprolol or low pressor. Class is a beta adrenergic blocker. Actions: metoprolol competes with adrenergic neurotransmitters such as catecholamines for binding at the beta-1 adrenergic receptor in the heart. The beta-1 receptor blockade results in a decrease in heart rate, cardiac output, and blood pressure. The harder, faster, and stronger portion has been pulled out of the equation if you use a beta blocker. Low pressor is utilized to decrease myocardial oxygen consumption, thereby reducing sudden cardiac death. Indications: acute coronary syndromes. Contraindications: known hypersensitivity, hypotension, or aortic pulmonic valve obstruction. Side effects: fatigue, malaise, depression, and impotence on low pressor. Dose: 50 micrograms per kilogram, slow IV push over about 10 minutes. Maintenance infusion of 0.375 to 0.75 mics per kilogram per minute. Special considerations: monitor the vital signs, cardiac rhythm, and blood pressure. Precipitation if infused with furosemide, so please keep it away from furosemide. Increased myocardial pumping efficacy and in-organ perfusion is what inotropic agents are for. And they pretty much increase contractile force strength. They increase peripheral perfusion, they increase stroke volume and heart rate, decrease preload and afterload on some of these, but those are going to be specific ones. Inamrinone, Lactate, or Inocor. The class is cardiovascular agent. It's an inotropic agent and a vasodilator. And just a quick review of what these things do. You're always going to spill into the previous container depending on which heart is failing. And for those of you all that don't know, you actually have two hearts. You have a right heart and a left heart. The right heart pumps blood into the pulmonary trunk, and the left heart pumps blood to the systemic vessels. So we have one pipe that goes all the way around, which is our vessels. I've drawn this one before in a previous slide set. So again, preload, afterload, and that's the pressure the heart must pump against. So if you have peripheral edema, what heart failure are you in? And the answer is you're always in the previous container. So you're having right heart failure. If you have pulmonary edema, then you have left heart failure. Now, the problem with some patients that are congestive heart failure patients, they'll start off with right heart failure, increase preload pressure and essentially be backed up, increase capillary pressure, increase afterload pressure, they become very hypertensive, and now the left ventricle cannot eject blood against that much pressure. So how do we fix that? We fix that in two ways. We dilate out the venous side. This is kind of the same thing that we do with nitrates and Lasix. And by dilating out the venous side, it gives the blood kind of a place to go. So you have a much larger container. That's where the vasodilator comes into place. And then the inotropic agent increases contractile force strength and ejection. So it makes the pump more efficient. So the combo drugs are what we're seeing that are used more and more. Primacor is one of those. Inocor or Inamrinone Lactate is another one. So that's what this medication does. Action inhibits peak 3 cyclic adenosine monophosphate isoenzyme and cardiac and vascular muscle. Exerts direct inotropic effect, which makes it beats harder. Achieves direct arterial vasodilation. Increases cardiac output. So if you can reduce the workload on the heart, the cardiac output, which equals stroke volumes times heart rate, increases. Decreases preload, systemic vascular resistance, and pulmonary capillary wedge pressure, which will assist the heart in perfusing better. Indications: congestive heart failure. Contraindications: hypersensitivity, aortic or pulmonic valve obstruction. Side effects: hypotension, thrombocytopenia, it's a possibility as well, low platelet count. Dose on this is 0.75 mics per kilogram, slow IV push over 2 to 3 minutes. Maintenance infusion is going to be 5 to 10 mics per kilogram per minute. Special considerations: don't mix it with furosemide or Lasix or dextrose containing solutions in this. So normal saline would be the perfect solution to mix this with. Monitor the vital signs, cardiac rhythm, and blood pressure. And that is the end of part 4. If you have any questions, feel free to contact me. My name is Roy Smith. Roy Smith at redlandscc.edu or smithr@emsa.net. Thank you.